Good evening, all. Today we'll discuss case-based approach, case-based discussion on COPD. So this is very important case for all sort of practical exams, even at the bedside also. Here we'll start with one of the hypothetical case and we'll put all probable questions which you can get at the bedside or maybe on paper discussion of your hypothetical case. So which may be computer based scenario or one-to-one discussion. So we'll take all the questions, all the highly expected questions in relation to COPD management and all. So 70-year-old male smoker, 3 days history of progressive breathlessness and 2 day history of fever with yellowish sputum. So he was also having a history of 40 pack years of the smoking. So he was irregular with his inhaler therapy in the past. So he was having a details which are very vague. So no history of chest pain or hemoptysis. So he was a diagnosed case of hypertension on amlodipine. So if you see his vitals on arrival to ER, so his temperature is 38.4 degrees Celsius, heart rate 114, respiratory rate 32. So there is a auxiliary muscle usage is there. Blood pressure is well maintained 134 by 78. So it's saturating around 82% on room air. How will you proceed? So elderly, background of smoker, hypertensive. So came with breathing difficulty, fever and productive cough. So we have the clarity on the diagnosis. So how will you proceed with this patient? Okay. So done with the focused examination, see, you need to answer like you are the first receiver of the patient. So there is a prolonged expiration, so diffuse wheeze on auscultation. So on percussion, there is a hyper resonant percussion, no crepitation, no edema. So is conscious oriented, is GCS 15. So next moment, what you need to do is like airway breathing circulation that remains common for all sort of patients. So controlled oxygen, because we know that the background of COPD, background of smoker with the defaulter of inhaler. So we have some thought process. Okay, we are diagnosing towards so maybe hyperreactive airway disease secondary to like smoking. So that is COPD. So controlled oxygen on Venturi. So 28% we like kept. So targeting a saturation of around 88 to 92%, secured the IV line and other monitors we connected. So immediate test we offered. So one is ABG. So with a current FiO2 that is 28%, ECG, X-ray. So basic biochemistry, RFT, LFT, CBC and electrolytes including magnesium, phosphorus. So we need blood and sputum culture because we know that so there is some problem with the background of sputum production, with the background of smoking history and is having a history of fever. So we send the cultures of this patient. Okay. So this is what we got. So analyze this ABG. So what disorder based on the ABG? So comment on the chest X-ray. So what is the diagnosis at this level? Okay. So if you see ABG, like his pH is 7.28, that is on a FiO2 of 28% on Venturi mask. So PCO2 is significantly high, 72, PaO2 is 58, bicarb 33. So it's like other parameters like lactate, sugar, so hemoglobin and ABG also looks normal. We got a CBC like its total count is 13,500, platelet 2,55,000, CRP is elevated 128, urea 46, creat 1.1. So its other LFT looks normal, electrolytes looks normal. Okay, so ECG shows sinus tachycardia. So these are some of the preliminary like investigation we had. So how we are going to analyze this ABG? So remember, when an examiner asked you to analyze the ABG, question is in depth. So answer also like you need to evaluate thoroughly. Okay. So it is not just what is the ABG. So then you can comment quickly on the important findings on and your working diagnosis, but he is asking analyze the ABG stepwise. You have to be very careful. So obviously patient is having acidosis with a pH of 7.28. So obviously when we have a high PCO2 of 72, so with the low pH, that is acidemia, with a bicarb which is moving towards like alkalotic, that is 33. So which suggests primary disorder is respiratory acidosis. That is a type 2 respiratory failure. So next question, whether is having a acute or chronic or acute and chronic respiratory acidosis. For that we need to get an idea about the compensation. Okay, so use expected compensation rules. We know that in acute scenario, bicarbonate rises by 1 milliequivalent per liter per 10 millimeters of mercury of the increase in PCO2. So here expected bicarb in this case is 24 plus 1 into 72 minus 40 divided by 10. So we got around 27 milliequivalent if we are having an acute like scenario, acute type 2 respiratory failure. If it is a chronic, so then we have a bicarb rise of around 3.5 to 4 milliequivalent per liter per every, so 10 millimeters of mercury rise in PaCO2. So their expected bicarb we get around 36.8. Okay, so observed value is 33, which means which is higher than that of the acute expectation, that is 27. So it is not purely acute, and which is lower than that of the chronic expectation. So chronic expectation is somewhere around 36.8, 37. So there is an inadequate for chronic. So there is some sort of superimposed metabolic acidosis is also there. So it is neither acute nor chronic. So next you check for the pH sanity. Okay, so basically, so acute pH drop is going to happen 0.08 for every 10 increase in PCO2. So if you see expected pH is equal to 7.4 minus of 0.08 into 3.2, that comes around 7.14. So chronic pH drop expected is 0.03 for every 10 okay increase in PCO2. So that comes around 7.3. So observed pH, that is 7.28 is the given pH on the ABG, which is closer to chronic, that is 7.3, but slightly more acidemic, which support acute and chronic respiratory acidosis with mild additional metabolic acidosis. Okay, so our compensation not yet complete. So conclusion here, so acute and chronic respiratory failure, okay, hypercapnic respiratory failure, that is type 2 failure with incomplete or insufficient metabolic compensation. So possibly mild normal anion gap metabolic acidosis may be there. So then when we have a metabolic component, what we do is calculate anion gap. So anion gap is 6, which means normal or low anion gap. So expected is around 8 to 12, which is 6. Okay. So there is no high anion gap metabolic acidosis. Slightly low gap can be due to lab variation or maybe low albumin or maybe chloride load, that is hyperchloremia. So further, no need to calculate any delta gap because it is not a high anion gap metabolic acidosis. So your complete analysis of ABG so takes you through all these steps. Very, very important. Okay. See, you might get this question or you might not get this question. But if you stuck here, so your Viva is not going to move further. So that's why you should be thorough on this. Okay. So next, some examiner may be interested to know the AA gradient. So oxygenation and AA gradient link, like we have a alveolar gas equation, that is alveolar partial pressure of the oxygen is equal to FiO2 into atmospheric pressure minus water vapor pressure minus PaCO2 divided by respiratory quotient. If you calculate, so which comes to a value of around 51.6 millimeters of mercury. Okay, here normal AA gradient for particular age is age divided by 4 plus 4. So patient is 70-year-old, so AA gradient expected should be around 21, but we got a value of around 51.6. So measured, that is around 52 is elevated, indicating an additional gas exchange defect beyond pure hypoventilation. Okay, so causes in this context, maybe patient is having a VQ mismatch, so likely due to COPD exacerbation, that is secondary to infection, secretion, atelectasis. So plus or minus, so there might be early shunt physiology. Okay, so that is the interpretation of high AA gradient. So beyond what we expected in this particular patient, that is obviously true here. Okay, so how to interpret the X-ray? So X-ray shows hyperinflated lung fields. So diaphragm appear flattened bilaterally, okay, with increased lung volume. So attenuated perihilar means attenuated peripheral vascular marking, okay. So consistent with emphysematous changes. So vertical narrow cardiac silhouette, okay. So tubular art appearance from the lung overexpansion. So patchy perihilar and basal opacity. So patient is having a perihilar and basal opacities more on the right side, okay, could suggest acute infective process. So example, infective exacerbation of COPD or is having a add-on pneumonia. So possible increased bronchovascular marking. So centrally maybe due to chronic bronchitis component. So there is a background of COPD, chronic bronchitis like picture with the acute infective exacerbation that is based on the X-ray. Okay, so these are the typical X-ray findings of COPD. So hilar enlargement, lung hyperinflation, okay, lucency of the increased lucency of the lung field and decreased lung markings. So increased size of retrosternal airspace. So increased anteroposterior diameter, flattening above the diaphragm. So sometimes if patient is having a bulle, we can get notified in the X-ray. So airway fibrosis like bronchial wall thickening. So that also some of the findings of like COPD patients, very, very important. So you can just so go through this summary. Okay. So basically like this patient looks like having a acute infective exacerbation of COPD. How you are going to define an acute exacerbation of COPD? Okay, so according to Gold 2024 definition, so acute exacerbation of COPD is defined as an acute worsening of baseline respiratory symptoms, particularly dyspnea, cough and or sputum that necessitates okay additional therapy such as antibiotics, steroids and with or without hospital based care. So that is the definition of acute exacerbation of COPD. So next question is going to be how you are going to have a severity based on gold or the recent revision of the gold criteria of the COPD. See, gold spirometric grading. So based on the airflow limitation, so post bronchodilator 1, 2, 3, 4. So if the like FEV1 percentage predictor is more than or equal to 80% mild severity, 50 to 80% moderate, so 30 to 50% severe, less than 30% is very severe. But we have gold combined assessment, that is a 2023 revision. So they grouped into ABC like based on the symptoms of modified medical research council dyspnea scale. If MMRC like symptom is more than or equal to 2, or there is something called COPD assessment test, if it is going to be more than or equal to 10, okay, so then so no symptoms more than or equal to 2, yes or any. So based on that exacerbation history like past year exacerbation, so 0 or 1 not leading to hospitalization, 0 to 1, 0 or 1 not leading to hospitalization, or more than or equal to 2 or greater than or equal to 1 leading to hospitalization. So this is how we can have a combination assessment based on the exacerbation with that of the modified medical research council dyspnea scale. So we have some additional classification like exacerbation risk. So like if more than or equal to 2 exacerbation or more than or equal to 1 hospitalization per year. So symptom burden. So MRC, modified MRC of more than or equal to 2 or COPD assessment test of more than or equal to 10. So blood eosinophils may guide inhaled corticosteroid usage of more than or equal to value of 300. So which is going to be likely benefited from that of the inhaled corticosteroid. So chronic bronchitis, so productive cough of more than or equal to 3 months in 2 consecutive years. So frequent exacerbator, so frequent exacerbation of COPD when he had more than or equal to 2 like moderate exacerbation or more than or equal to 1 severe exacerbation per year. Okay, these are some different terminologies. If your examiner is from a pulmonology background, so you can expect all these questions, very, very important. Okay, so severity classification is based on so healthcare utilization also. Mild we can manage with short term like short acting bronchodilators only. Moderate require systemic steroid and or antibiotic. Severe require hospitalization or emergency visit. So most often triggered by respiratory tract infection, viral, bacterial, sometimes environmental pollutants, or sometimes it may be idiopathic as a trigger for acute exacerbation of the COPD. So again, it's a so very important concised slide. Okay. So what are the common infective etiology for acute exacerbation of the COPD? So what are the infective causes? So we have like bacterial, Haemophilus influenza, Moraxella, strep pneumoniae, Klebsiella. So Haemophilus, strep pneumoniae, Moraxella, these are common in India also. So next we have Klebsiella, Pseudomonas, particularly in severe COPD or frequent exacerbation, or if they are having an underlying structural change like bronchiectasis, interstitial lung disease pattern also. Acinetobacter is very rare community acquired, which is common in ICU setting. Okay, so Pseudomonas more common in advanced disease or with the patients who are malnourished, ethanol abuse, prior antibiotic, or bronchiectasis patient. Viral, so influenza A or B, respiratory syncytial virus, human metapneumovirus, rhinovirus, SARS-CoV-2, that is COVID. So viral triggers often predispose to secondary bacterial infection. Atypical bacteria like Mycoplasma, Chlamydia, and Legionella, so less common but still possibility. See, if it is a primary community acquired pneumonia, we can have a atypical organisms also. So fungal, very rare. So only aspergillosis in immunocompromised or prolonged steroid usage with COPD background, there is a possibility of the invasive aspergillosis in the lung. So usually they are colonization unless proven invasive on the image. Okay. So what organisms we need to cover in terms of empirical therapy? So primary coverage, at least as I told, Haemophilus influenza, strep pneumonia, Moraxella. In severe cases or high risk patient, so cover Pseudomonas klebsiella, especially so in a gold stage D, frequent examination, prior hospitalization, or if they are having underlying structural lung disease. So viral, definitely seasonal influenza virus. So empirical antiviral, if suspicion is high or confirmed with the outbreak, so then we need to cover the so H1N1 pneumonia or COVID according to the outbreak of that particular virus. Okay. So what is the first line of antimicrobial therapy in COPD? I told which organism we need to cover, but what is the data suggesting which one to use? So first line anti-infectives, mild to moderate exacerbation. If there is no risk for Pseudomonas, so oral we can give amoxiclav, doxycycline, or respiratory quinolones. Okay, so like Cleoflox, Moxiflox, but we worried about like tuberculosis, grass resistance, and all that you need to keep in your mind. So IV option, if unable to take orally or more severe case, so then ceftriaxone or ampicillin sulbactam is the recommendation. Okay, severe exacerbation or if they are requiring ICU, risk of Pseudomonas is there, like their FEV1 is less than 50% of expected, frequent exacerbation, recent antibiotic bronchiectasis, so then IV piperine tazobactam to cover Pseudomonas, sometimes 4th generation cephalosporin cefepime or maybe ceftazidime is indicated. So if you are suspecting an ESBL risk with a prior colonization with a GNB, resistant GNB, so then carbapenems. If high suspicion of MRSA like post-influenza pneumonia, prior MRSA colonization, we can take a call on going for linezolid or vancomycin. We know that linezolid is having a good lung penetration as compared to glycopeptide, that is vancomycin. So there is a cross molecular mimicry. If they are having a influenza pneumonia, so there is a more susceptibility to have a MRSA infection also. So antiviral in acute exacerbation of COPD. So oseltamivir oral if influenza suspected within first 48 hours of symptom, or during local outbreak, or if you have a confirmed exposure. Okay, so remdesivir, so we have a data which is not very good. So if you wish, you can use when there is a confirmed COVID and patients meet the severity criteria. So what is the duration of therapy? See, the lowest duration for infective exacerbation of COPD is somewhere around 3 to 5 days for uncomplicated case. So 7 to 10 days in severe illness, slow responders, or in patients with Pseudomonas. So Indian nuisance like nuns we have. So in severe COPD with a prior ICU admission, we often see drug resistant gram negative organisms, particularly Pseudomonas, Acinetobacter. So early escalation guided by prior culture history or antibiogram is very, very essential. So empirical antifungal is not recommended unless strong evidence of invasive fungal infection is there or if patient is immunocompromised. Okay, so this is just an overview on the antimicrobial therapy in acute infective exacerbation of the COPD. Okay, so what are the overall therapeutic options we have? Okay, this is the comparative table. So based on their weightage in COPD, we have inhaled beta like agonist, good weightage, inhaled anticholinergic, good weightage. So systemic steroid may not be very good as compared to that of asthma, but required in severe cases. Antibiotic, if it is infective exacerbation, definitely yes. Oxygen, so we need to cautiously titrate. Non-invasive ventilation, very good evidence for COPD. So broncho like mucolytics and phosphodiesterase inhibitors like thiophyllene and all don't have a very good evidence in COPD because of lots of adverse effects involved. Okay, so we'll try to understand. So with the questions particular to this case, so where how we can utilize all these therapeutic option in our particular patient. Okay, so comment on the dose, duration, and type of steroid in COPD. Again, I am telling you, see some questions you might get So with a thorough in-depth discussion, some questions they just want answer yes or no. Okay, but you need to prepare thoroughly. That is very important. So type and route, oral steroid like prednisone or prednisolone are as effective as IV. Need not to go for IV always, and are preferred if the patient can tolerate oral intake. So example, so prednisolone 40 milligram per oral daily or its equivalent any steroid is fine. Even you can use hydrocortisone 100 milligram 8 hourly, which is equivalent to 40 milligram of prednisone. Okay. So daily recommended dose of prednisone is 30 to 40 milligram or per kg, that is 0.5 to 0.6 milligram per kg. So duration, lots of data is available. 5 days duration is a new standard duration. So short course, that is less than or equal to 7 days, typically 5 days are non-inferior to prolonged duration regimen, that is 10 to 14 days. Okay. So in terms of treatment failure, relapse rate, so time to next examination, hospital length of stay, lung function improvement, symptomatic relief, so adverse event rate, that is hyperglycemia, so which is non-inferior when it comes to 5 days therapy as compared to 10 to 14 days therapy. So even GOLD 2019 2024 and other guidelines recommend 40 milligram of prednisolone daily for 5 days with no need of tapering up of the dosage. So that is on the steroid duration. Okay, so these are in and around steroid in COPD, the evidence. Okay, in terms of the route, so in terms of recommended dosage, duration. Okay, so this is one of the landmark trial, reduced trial. So NEJM 2013, so which clearly suggests 5 days course non-inferior to 10 to 14 days in terms of relapse, mortality, lung function, hospital stay. No need to taper. If you give a steroid of less than or equal to 2 weeks, okay, you can stop abruptly after 5 days. Okay, so again, high dose definitely, so like leads to more chance of hyperglycemia, infection, increased length of stay. So low dose is equally effective. Okay, so steroid, even in Cochrane meta-analysis, so American Thoracic Society, European Respiratory Society guidelines, so everywhere suggest benefit in terms of improvement in the FEV1, so PaO2 symptoms, reduce relapse rate, treatment failure is going to reduce, so it is going to shorten the hospital stay. Okay, so high dose definitely keeps increasing the incidence of hyperglycemia, infection, myopathy, delirium. No need to go for the high dose. So this is the comprehensive slide which gives everything in and around the steroid in COPD. Very, very important. Okay. What is the role of mucolytics in acute infective exacerbation or acute exacerbation of COPD? Can we use mucolytics with a very good evidence in our particular patient who is a 70-year male, so with a background of smoking, who presented with acute infective exacerbation? We'll try to understand the evidence. Okay, if you see, most commonly used like mucolytic is N-acetylcysteine, so which suggest reduction in exacerbation in chronic bronchitis and COPD. So benefit when you use at least around more than or equal to 1.2 gram per day as the dosing. We had one trial, that is PEACE study in 2014, so where they used erdostine 300 milligram BD, so which helped in reducing the exacerbation rate and antibiotic use in COPD. So benefit which is independent of inhaled corticosteroid usage. So HIAS study 2013, so NAC 600 milligram BD, so reduce the inflammation, improved small airway function in COPD. So especially it is the data particularly came from Chinese population. So what is the GOLD 2023 recommendation? Use in chronic bronchitis plus when they have a frequent exacerbation. So if they are not on inhaled corticosteroid. So that is also conditional recommendation, moderate quality of the evidence. So do you think is there any very good evidence for NAC in COPD? Answer is no. Okay. So in particular individual patients only we can use mucolytic therapy. That is the take home. So can you enumerate so bronchodilator options and recommendation in acute exacerbation of COPD? Okay. So basically what agent to be used, which is the first line of therapy, what are their limitations and all. Okay, so first line always short acting beta 2 agonist. Okay, so like salbutamol, usually we can give 2.5 milligram via nebulizer or 100 mcg, so meter dose inhaler, 2 to 4 puff every 1 to 4 hour depending upon the need, so which is helping in rapid bronchodilation, most commonly used initial therapy. So plus or minus we can go for short acting anticholinergics, that is like muscarinic agonist, that is ipratropium, so 0.5 milligram nebulizer every Q 4 to 6th hourly. So in combination with SABA, which is superior to either alone also. That is a goal 2023 recommendation. Second line, systemic steroid. So as we already discussed previously, so like long acting bronchodilators like beta 2 agonist or muscarinic agonist start after stabilization. So not during the acute phase. No need to give using during the acute exacerbation of the COPD. For maintenance, okay, so not for acute management. So it is going to helpful in the long-term maintenance. So third line, magnesium sulfate IV, 2 gram IV over 20 minutes. It is an optional, may be helpful in severe bronchospasm, but we have a limited evidence. So methyl xanthines like thiophyllene, okay, so aminophylline and all, which is rarely used in the acute setting. So because of narrow therapeutic window and not routinely recommended. So in acute exacerbation, lots of adverse effect in terms of arrhythmia, drug interaction and all. So the key evidence is with nebulized versus MDI. Both are equally effective. So either you can go for a jet nebulization or MDI puff. Both are equally effective. So like if patient can use MDI with spacer properly, we can go for MDI also. So combination therapy, that is SABA plus SAMA, improves FEV1 and symptom relief in moderate to severe acute exacerbation of COPD. So LABA and LAMA initiated only after initial stabilization, not during acute exacerbation phase. So inhaled corticosteroid and LABA combination, so reserved for patients with eosinophilia or frequent exacerbation post recovery. So that is about the bronchodilators in acute exacerbation of COPD. Okay. So what is the next line of management? So what we done? So empirical therapy like nebulized salbutamol and ipratropium we started in our patient. So started methylprednisolone 40 milligram IV OD. So injection piperacin tazobactam, injection azithromycin has been started because patient elderly with bad history of smoking. Okay, so like risk categorization we thought will like because of the severity. So we like target the pseudomonas also. We started on the DVT prophylaxis. What important other therapeutic intervention is needed at this level? Okay, so there is no doubt patient is having acute and chronic type 2 respiratory failure, tachypnea is there. Okay, so we have done some part of the medical management hand in hand. One of the major therapeutic intervention is needed, that is the non-invasive ventilation. Okay, so what is the evidence for NIV here? Okay, what are the contraindications? So your examiner is going to ask when you wish to use NIV in COPD patient. So evidence is in acidotic hypercapnic exacerbation when they have a pH of less than 7 point, less than or equal to 7.35, PCO2 of more than 45. So NIV helps in reducing intubation need, mortality, length of stay. See, NIV is one of the main therapy which reduce the mortality in acute exacerbation of COPD. Also, it improves pH and CO2 within hours. So strongest benefit for NIV when the pH is between 7.25 to 7.35. So when the respiratory rate is like more than or equal to 24 to 25. So in a cooperative patient. Okay. So absolute contraindication, imminent like respiratory arrest or cardiac arrest, inability to protect the airway, intractable vomiting, facial trauma or surgery, severe unstable hemodynamics, unstable arrhythmia. So these are some of the contraindication examiner might be interested to know from you. So relative contraindication are when they have copious secretion, so high risk for aspiration, poor fitting mask, severe agitation. Okay, even in patients with a poor GCS, not less than 7, less than 8 and all, but somewhere around 10, okay, 9, 11 GCS also we can try the NIV in COPD patient. Okay, there is a data on that. So action, start NIV BiPAP if no contraindication. Initial setting, IPAP of 14, EPAP of 5, FiO2 titrate to saturation of around 88 to 92. So bronchodilator through the circuit, so which is having a port for it. So steroid you need to continue. So like proper achieve the mask seal and all. See, they will definitely ask how you are going to initiate the NIV. What are your setting of the NIV? Okay. So if you once like indication is confirmed, so confirm the patient meets the indication for NIV. Moderate to severe dyspnea with auxiliary muscle use or paradoxical breathing is there. Respiratory rate is more than 24, pH is less than 7.35, PCO2 is more than 45 with type 2 failure. So no immediate need for the intubation, stable hemodynamically, cooperative. That is what in our patient. NIV most effective with a pH of 7.25 to 7.35. So oronasal mask is preferred in acute exacerbation. Okay, it is the first line in acute exacerbation of COPD. Avoid nasal mask in acute setting due to inadequate tidal volume because it is going to keep the mouth opening. So ensure proper mask fit to minimize the leak and improve the comfort. Okay, so initial setting, like target tidal volume somewhere around 6 to 8 ml per kg. Avoid high volume to prevent dynamic hyperinflation. Use ST mode in a BiPAP. Okay, IPAP of around 10 to 12, EPAP around 4 to 5, FiO2 as I told, target SpO2 of 88 to 92, backup rate keep around 12 to 14. See, when an examiner asks what are your initial setting of BiPAP, you should tell the backup rate also. Very, very important. Okay, so in the first 1 to 2 hours, immediately monitor for the response. So monitor for vitals like heart rate, respiratory rate, blood pressure, saturation. After 1 to 2 hours of NIV, look for pH improvement, PCO2 should reduce. So there should be like improvement in the PaO2. Okay. So patient comfort, you need to evaluate. Synchrony should be very good synchrony. Otherwise, it leads to breath stacking and dynamic hyperinflation. Check for air leak. If poor response, like no pH improvement or raised PCO2, consider escalation. Okay. So if dyspnea persists, like IPAP can be increased by 2 centimeter, maximum we can go up to 20 to 24 centimeter cautiously. If oxygenation is poor, so then we can improve the EPAP by 1 to 2 centimeter up to 8 to 10 centimeter of water maximum. So always increase IPAP and EPAP in parallel to maintain the driving pressure. So the difference so should be at least 4. You increase the IPAP significantly and you don't increase the EPAP, that should not be happen. So like you need to increase both parallel so to maintain the adequate driving pressure. Okay, so this is about the initial setting of NIV in our particular patient. So how you are going to have a criteria for failed NIV? So if the following occur, consider the intubation, like pH is still less than 7.25 even after 2 to 4 hours of NIV. Okay, so persistent worsening hypercapnia, severe agitation or reduced consciousness if GSS is less than 8. See, up to 8 we can try NIV even in acute exacerbation of COPD. Or if patient is becoming unstable hemodynamically, copious secretion, there is a risk of aspiration. So then you need to consider, so he is having a failed NIV. So after 2 hours in our patient, so pH is remain in and around the same, PCO2 is still 76, PO2 is 62, okay, bicarb is 34, so it's still tachypnic, so FiO2 requirement become 40% now. So is slowly becoming somnolent. So basically, so is not a very good responder to NIV. What next? What else will you investigate now? Okay, so basically here the question is, so how you are going to troubleshoot when a patient is not responding to NIV? So as I already told, check for the leak. So asynchrony, agitation, it may be inadequate IPAP. So IPAP, you can go up to 16 to 18. Ensure enough expiratory time is given. So reduce the backup respiratory rate. So optimize the bronchodilator, manage the secretion, consider small dose of anxiolysis. You can consider giving a small dose of sedative benzodiazepine also at this level. Okay, if deteriorating consciousness like pH is less than 7.25, so proceed to intubation. Also again confirm chest x-ray, ECG, full labs culture. If not like already sent, okay, get the report if it is already sent. So indication for intubation in this scenario, so if there is a worsening acidosis, as I already told, worsening oxygenation, worsening GCS, so copious secretion with increased risk of aspiration, so unstable hemodynamics arrhythmia, so you need to consider intubating the patient. So on NIV, patient is still deteriorating, so decided for intubation and initiating a mechanical ventilation. So we intubated the patient. Okay, so after intubating, so what is the post intubation mechanical ventilator strategy in this patient? So how we are going to ventilate? So which mode? So what tidal volume? So what is your plan post intubation in our patient who is not having a tolerability or not improving any sort of his clinical scenario after putting him on NIV? Okay, so we should have a defining strategy and initial ventilator setting for COPD exacerbation and all. So first thing, like we need to avoid hyperinflation and its associated complications like trauma, barotrauma, and hemodynamic compromise should not happen when you set the ventilator. So controlled mode of ventilation so that expiration is as long as possible. So lower respiratory rate, so that if you keep a respiratory rate low, automatically it gives more time for expiration. Okay, so tidal volume is kept low to avoid dynamic hyperinflation. Okay, so we call it as a controlled hypoventilation or permissive hypercapnia. So low expired minute ventilation, minute volume, okay, with a high inspiratory flow. When you increase the inspiratory flow, obviously your inspiratory time is going to be reduced, so which is going to like expiratory ratio means uh, your expiratory time is going to be automatically increased. So minute ventilation should be less than 115 ml per kg. Tidal volume should be less than 6 to 8 ml per kg. So respiratory rate somewhere between 10 to 14 per minute. Inspiratory flow around 80 to 100 liter per minute. So PEEP of around 3 to 5. Titrate, so FiO2 to saturation of around 88 to 92%. I ratio somewhere around 1.3, 1.4 you can maintain. See, you should tell some setting to your examiner. So this you can remember for all your practical purpose. Okay, these values. So aim at normal pH rather than normal PCO2. We don't want normal PCO2 as long as we are able to achieve the normal pH. That is the like goal in ventilating the acute exacerbation of COPD. So can you compare volume control or pressure control mode in COPD? Which is better? Is there any evidence like that? So if you see, lots of data is available. So these are the data which you can go through. So nothing is like having a very good weightage in terms of volume control ventilation versus that of the pressure control ventilation in acute exacerbation of COPD. Okay, so there is a data in terms of efficacy, volume control and pressure control ventilation similarly improve gas exchange and ventilation in acute exacerbation of COPD. So in terms of safety, pressure control ventilation generally has a lower peak pressure and lower chance of the barotrauma risk. So pressure regulated volume control ventilation, that is PRVC, may offer an ideal balance of volume controlled but pressure limited ventilation. So work of breathing, the pressure controlled ventilation may reduce work of breathing, especially using moderate tidal volume with a decelerating flow. In terms of weaning, volume support mode may facilitate faster weaning compared to pressure support mode. But in terms of overall mortality, okay, so either pressure control or volume control both are having a equal weightage. That should be your answer. So, but you just go through some of the important highlights in terms of different modes of ventilation. So, in acute exacerbation of COPD. Okay, so this is the table of the landmark trial, so which you can go through in like ventilating the acute exacerbation of COPD patient. Okay, so he is intubated and mechanically ventilated in volume controlled mode. So comment on the ventilator graphic, what's happening here. Okay, how you are going to troubleshoot this patient who is elderly with the background of smoker, who failed with NIV, got intubated, who received antibiotic, bronchodilator, steroid. So this is the ventilator screen on volume control mode. So you can expect ABG, X-ray, ECG, ventilator screen, okay, biochemistry, everything you can expect in your like practical computer based scenario. You need to prepare for all those things. Okay, this is the ventilator. So this is the flow versus time, pressure versus time scalar. Okay, so this is the volume versus time scalar. What's happening here? If you see, patient is having a auto peeping, so there is an incomplete emptying, so there is a air trapping before expiration touches the baseline, inspiration is starting. Okay, so there is a air trapping, so there is a dynamic hyperinflation, that is because of the auto peeping. So expiratory flow waveform fails to return to zero, indicating incomplete exhalation before the next breath is initiated, which suggests dynamic hyperinflation commonly seen in obstructive lung disease, particularly in acute exacerbation of COPD. So this increases the intrathoracic pressure so that it reduces the venous return. So it also increases the barotrauma because of a reduced preload. It also causes some sort of like your problem with that of the unstable hemodynamics, and also that is the sequelae of auto peep. When there is a auto peep, when you plan to put him on spontaneous breathing, so he is not able to trigger the ventilator, that leads to asynchrony, desynchrony with increase in work of breathing. So these are the adverse effects of the auto peep. How to troubleshoot? Okay, so either reduce the respiratory rate, so to prolong the expiratory phase so that there is a adequate time given for exhalation. So reduce the tidal volume, target maybe 6 ml per kg of the ideal body weight as like in ARDS. So that is also we give as a some sort of like protective ventilation. So bronchodilator, so steroid, decrease respiratory rate, increase the E ratio, okay, shorten the expiratory time. Like, so it is shortening inspiratory time, so that it increases the expiratory time, not the expiratory time shortening, it is inspiratory time shortening, okay. So sometimes we need to accept the permissive hypercapnia. So if there is a problem with secretion, kinked endotracheal tube, water in the tube, so that you need to take care. So over assistance in patient triggering, like sometimes, so adjust the trigger sensitivity, switch to control mode temporarily. So auto triggering, if it is there because of leak or inappropriate triggering sensitivity, so check the trigger setting and fix the circuit leak. So these are some of the troubleshoot which you can do for troubling, means like for treating the dynamic hyperinflation and that of the auto peeping. Okay. So how will you measure auto peep? So when and how much external peep to apply? So we know that. So one of the method what we can do to like compensate or overcome, so is we can go for extrinsic peep application, but before that we should know how to measure the auto peep. Okay, so basically, so understand the prerequisite. So auto peep can only be accurately measured in passive patients, not if they are having a active breathing. Okay, so during controlled mechanical ventilation, most reliably in volume controlled method, so use an end expiratory hold. So in the ventilator, there is a button for expiratory hold or end expiratory pause. So hold it for 0.5 to 2 seconds. So that usually is sufficient. So this is essential, which occlude the airway at the end of expiration, which allows alveolar pressure to equilibrate with that of the airway pressure. In spontaneously breathing patient, auto peep can't be directly measured using expiratory hold. Instead, so we can measure it by using esophageal pressure monitoring, so which helps in estimating the transpulmonary pressure, so which is complex but rarely used routinely at the bedside. So or evaluate the flow time loop in spontaneously breathing patient. Look for incomplete return to baseline, that is zero is not touched before the next inspiration, which suggests there is the air trapping, and it is one of the qualitative evidence for auto peeping in spontaneously breathing patients. Okay, so this is how like you can check for the auto peeping. So when to apply extrinsic peep? So when you are going to apply, so anytime when patient is having auto peep, so external peep, okay, can be and should be applied to decrease inspiratory trigger effort. But remember, so this external peep may be of use in counterbalancing intrinsic peep, that it helps in reducing the work of breathing, so but it doesn't help in minimizing the hyperinflation. So not to apply extrinsic peep in fully controlled mode, okay, then it may worsen the hyperinflation. So extrinsic peep is advised to apply in assisted spontaneous breathing mode, so that it helps in reducing the inspiratory trigger of work, overall work of breathing. So how much peep extrinsic should be applied? So it is defining an adequate amount of external peep is difficult. So thinking of the waterfall principle. So remember, so we need ideally extrinsic peep is equal to intrinsic peep. So but so we can't go for equal adding the extrinsic peep, because there might be mixed picture of airflow limitation and airflow, there is no airflow limitation, because so in the intrinsic peep distribution within the COPD or in asthma, so lung, that is distribution is uneven, so because of an inhomogeneous time constant distribution, so thus in some areas effective peep, that is intrinsic peep, might be lower than the measured static peep, that is the intrinsic peep, so which leads to an increased total peep. So that's why we don't apply extrinsic peep which is equivalent to that of the intrinsic peep. We go for 80% of the intrinsic peep because of the inhomogeneous time constant. So some areas it might be more, some areas it might be less. If we add equally, so then it may become additive. So that's why we go for 80% of the, so measured means extrinsic peep, we give 80% of the intrinsic peep which we got from the end expiratory pause. Very, very important. Okay, that is during only spontaneous breathing, not during the control mode. See, that is a clinical problem in applying the extrinsic PEEP. See, we are measuring end expiratory hold and that of the peak, auto PEEP, intrinsic PEEP during the controlled ventilation. when patient is very well sedated or maybe paralyzed. But we are applying the extrinsic PEEP for the spontaneously breathing patient and all. Okay, so that's why it is very difficult to quantify whether it is helping or not. Only way is see for the patient comfort. So is dyspnea synchrony is improving. Okay, after applying the extrinsic PEEP. So you will notice the relief of workload due to counterbalancing of intrinsic PEEP until hyperinflation is increasing. So that is how we can get an idea. So by checking whether patient is comfortable, his work of breathing is reducing. So it means, so whatever the extrinsic PEEP you applied to counterbalance the auto PEEP is helping to that particular patient. Okay. So coming back to our patient was on mechanical ventilation. So on volume control ventilation. So following is the ABG. See, in the due course, there is a sudden drop in blood pressure to 86 by 56 millimeters of mercury. Initially, he was having a very good pressure around 130, 140 like that. So how to troubleshoot this condition? If you see, pH is 7.15. This is on mechanical ventilation, volume control ventilation. So PCO2 become 92, PaO2 is 90, bicarb 34. Okay, so it's saturating 96%. So on FiO2 of 40%. Main two things, worsening type 2 failure and unstable hemodynamics. How you are going to troubleshoot this patient. Okay, so basically is having an hemodynamic compromise because of the auto peeping. Okay, so there is an increase in intrathoracic pressure, so it reduce the venous return to right side. So whenever there is a reduction in venous return, so that reduce the like cardiac output. So there is a compromised like blood pressure. So disconnect the ventilator circuit, so that we call it as air dumping, and it should improve the hemodynamics. See, once you disconnect the ventilator circuit, whatever auto peeping is there, so is going to get relief transiently, so that his cardiac output will improve, his hemodynamics should improve. Okay, so what other troubleshoot you can do to tackle this refractory hypercapnia? So again, shorten the inspiratory time, so it helps in increasing the flow, prolong the expiration, reduce the respiratory rate. So modest tidal volume around 6 to 8 ml per kg, minimize the dead space, remove extra connectors, consider so HME or bulky HME. Okay, so heated humidifier you can connect over that of the bulky HME. Optimize airway, like bronchodilator frequency you can increase, do proper suctioning. So here you can consider using mucolytics if needed. So measure the intrinsic PEEP as I already told. So apply like around 80% of the intrinsic PEEP, that for the extrinsic PEEP, that is only during the spontaneous breathing. Accept the permissive hypercapnia. So if you are not able to tackle this problem, if pH is not compromised, if it is more than or equal to 7.2, so if there is no contraindication, like there is no raised ICP, there is no severe pulmonary artery hypertension, no RV failure, no ongoing arrhythmia, so then we can accept this permissive hypercapnia. So treat non-pulmonary drivers. The patient is having fever, shivering, that increase the CO2 production, that you need to troubleshoot. So sometimes like one option is extracorporeal CO2 removal. We have like ECCO2R, which we call it as respiratory dialysis or a low flow ECMO. So which is mainly meant to remove the carbon dioxide, so that we can achieve the lung protective ventilation without much advantage for oxygenation. That is one of the option for extracorporeal CO2 removal. So then analyze the waveform. So if there is a air trapping, okay, so that you need to troubleshoot. Sometime your expiratory flow limit, okay, so instead of 25% by default, you need to increase to 40-50%, so that there is a early winding up of your like inspiration, automatically which switch to expiration, which gives the adequate timing. So that we can change, that is the percentage of the expiratory trigger we call it as. Okay, by default it is usually set at around 25%. You can increase that. That also helps in one of the troubleshoot for refractory hypercapnia. So this is again the table what we can do in terms of ventilator intervention to get an idea about so like washing out the PCO2 when patient is on mechanical ventilation. Okay, so day 3, so see the labs here, there is an increase in WBC count, so its neutrophil count is 86%, CRP is increasing, we got a procal of 6.2, serum lactate is increasing 3.5, X-ray shows new infiltrates, so consolidation. Okay, so sputum ball culture has been sent, so like PF ratio is dropping, so is respiratory acidosis with hypoxia is also there. So this is what happened in terms of the culture sensitivity report what we got. So like infiltrates here, okay. Like infiltrates are in the left side, not in the right side. So basically, so there is an increase in infiltrates in the left side. So with Pseudomonas in the ET aspirate which we sent. So this is the MIC value. Okay. So if you see, it is intermediate sensitive to colistin and resistant to almost all the commonly used BLBLIs and other carbapenems and all. What's your antimicrobial plan now? So initially he was on piperacin tazobactam, but it grown a Pseudomonas which is resistant. Okay, so he was also atypical coverage, that is azithromycin. So comment on combination therapy. Can we go for nebulized antibiotic in a patient who begin with infective exacerbation of COPD? Now we stuck with ventilator associated pneumonia, add-on complication. Okay, so what we done? We started IV colistin like full dosage 9 million unit stat followed by 4.5 million unit BD. So later, depending upon clinical improvement and renal function, you can adjust. But remember, if patient is deteriorating, don't go for straight away adjusting the dosage of colistin as per the react clearance. You taken into consideration of the clinical profile also. So consider adjunct nebulized colistin. So if there is a high burden of like airway colonization and VAP, but nowadays even IDSA is also not strongly recommending like nebulized colistin as a mandatory or nebulized antibiotic. But if at all using a nebulizer, it is always with the like systemic therapy, not as a standalone therapy. Standalone therapy you can give only when patient is having ventilator associated tracheobronchitis, so not in VAP. Okay, so we should use ultrasonic nebulizer or vibrating mesh type of nebulizer, not the jet nebulizer which we use for giving a bronchodilator. See, we want colistin to reach the alveoli. For that, we need a breakdown of the molecular size less than 5 micron. That will happen only with ultrasonic or vibrating mesh nebulizer. So jet nebulizer which helps in bronchodilation. Okay, so that is the purpose for jet nebulizer. So discuss combination or synergy testing with the microbiology. We can check synergy of ceftazidime avibactam plus aztreonam. Even though it is resistant to ceftavi, sometime for combination therapy it may retain the synergy. So remember, so you need to give ceftazidime avibactam through one line and aztreonam through one line simultaneous infusion. So not as a back-to-back kind of this one. Okay. So don't give any other random combination therapy. So strict aseptic precaution, infection control policies, and later source control, de-escalation, all these things you need to consider in a particular patient. Okay. Beyond ventilation and antibiotics, what ICU supportive care is essential? See, you escalated the antibiotic on mechanical ventilation, colistin has been given. So other than like protective ventilation, what other ICU supportive care is essential? So nutrition, no doubt. So at least 25 to 30 kilocalories per kg per day, protein of 1.2 to 1.5 gram per kg per day. Avoid excessive carbohydrate in profound hypercapnia. See, there is no role for like removing the total carbohydrates at all. Okay, so that is not recommended, but don't go for excessive carbohydrate. So if patient is having a profound hypercapnia, fluid and electrolyte balance, keep them U balance, give weightage to phosphorus, potassium and magnesium because phosphorus is very essential for respiratory muscle functioning. So thromboprophylaxis, low molecular weight heparin, stress ulcer prophylaxis, physiotherapy, airway clearance with when the patient is stable, mobilization, fluid as I already told, euvolemia, avoid volume overload which may worsen the gas exchange, glycemic control somewhere, sugar target between 140 to 180. See, these patients already on steroid, you need to target the sugar of 140 to 180. So daily sedation interruption, so lighten daily, prevent delirium, so address the anxiety, improve synchrony and weaning. So if you address the anxiety properly, so weaning plan you should have in hand when the infiltrates are reducing. Okay, so daily weaning screen you should assess. So these are the add-on supportive care which you are going to do in a COPD patient. Okay, so comment on evidence for specific nutritional consideration in COPD. Take home is we can give carbohydrate, no need to totally avoid. Okay, because so even if you reduce or remove the carbohydrate, there is no significant long term survival benefit. Okay, so like not extreme carbohydrate elimination is recommended. So the take home is consider carbohydrate restriction in extremely hypercapnic COPD patient, especially in intubated, ventilated. If you are not able to control the carbon dioxide at all, so then only you can restrict. Otherwise, there is no role for restricting the carbohydrate. So tailor nutrition to patient's metabolic profile and comorbidities. Evidence support reduced carbon dioxide production and ventilatory demand, but no data on long-term data. Okay, so avoid one size fit all approach. So no need for totally avoiding carbohydrates. Okay, you can give adequate carbohydrate, but excessive carbohydrate is not needed. Okay, so and restriction is needed on one-to-one basis, not on a general approach. Why? Because if you see, respiratory quotient of carbohydrate is 1. For fat, it is 0.7. So lower the respiratory quotient from fat, so it helps in reducing the carbon dioxide production and all. So high carbohydrate intake increases the CO2 production via high respiratory quotient, which can exacerbate hypercapnia in COPD patient. So that is the rationality. We thought, okay, we need to restrict, but there is no data clearly suggesting you need to restrict in all patients of the carbohydrate. Okay, that is the take home. So on day 6, following are the patient's clinical findings. So his temperature is 36.9. So no fever, heart rate is okay, blood pressure 124 by 78. So on 30% FiO2, saturation is 94, urine output is good, like at least he is maintaining more than like 0.5 ml per kg per hour. So chest auscultation, decreased V's. So X-ray, hyperinflated lungs, no new infiltrates. So like we stopped the sedation for 6 hours, stable hemodynamics, tidal volume, minimal secretion. But we got the ABG. ABG shows pH of 7.46. Okay, like PCO2 is 65, PO2 is 68, bicarb is 45. So other parameters are normal. So what's happening here? Okay, minimal FiO2 requirement. Okay, around 28 to 30% FiO2. So analyze this ABG. What is the probable troubleshoot which we can consider? So even though it's having a limitation, so it's having a like compromised pH which is toward the alkalotic pH. Okay, so this ABG is the chronic respiratory acidosis. So there is a expected bicarb increases, so 3.5 to 4 milliequivalent per liter for every 10 millimeters of increase in PCO2 above 40. So PCO2 increase 65 minus 40, 25 millimeters of mercury. So expected bicarb is around 36, but measured is around 45 in our EBG. Okay, it is higher than the expected, which suggests there is a superimposed metabolic alkalosis, which is likely due to steroid use. So diuretic, vomiting, chronic hypoventilation, these are some of the causes for so very high metabolic acid alkalosis with the bicarb which is around 45. Okay, so this is usually a chloride responsive metabolic alkalosis. If you see the urinary chloride, which is going to be less than 20. So here, so there was one thought process, can we use acetazolamide? Okay, so it is a carbonic anhydrase inhibitor. Okay, initially lots of data came in using acetazolamide post hypercapnic, okay, metabolic alkalosis. So physiological benefit studies consistently demonstrate biochemical correction, lowered bicarbonate and PCO2, improved pH and oxygenation, but clinical benefit data do not demonstrate a clear benefit in terms of shortening mechanical ventilation or weaning, reduction in ICU or hospital length of stay, or improvement in the mortality. So sometimes you can have a adverse effect, okay, electrolyte disturbances with the acetazolamide. So certainty of evidence, there is largely low quality, low to moderate quality evidence, so limited by small sample size, heterogeneity and underpowered trials. So there is no generalizability on using acetazolamide in patients with a COPD who had a post hypercapnic metabolic alkalosis. So this is one of the Diabolo trial which got published in 2016. So which showed duration of invasive mechanical ventilation. So weaning time, there is no significant reduction in ventilation duration or weaning time with acetazolamide as compared to that of the placebo. Basically, we don't have a very good like some sort of evidence to suggest usage of acetazolamide in patients with like metabolic alkalosis with a background of COPD secondary to post hypercapnia. So that is the take home. Okay. So, what is the role of early tracheostomy in COPD? See, now we reached our patient in around 7 days. So, should we consider early tracheostomy? Answer is no, because even though COPD required prolonged mechanical ventilation, so we can have a difficulty in weaning. So, early tracheostomy is not be considered in general because the decision making is complex. So, they will have a dynamic hyperinflation, air trapping, poor respiratory drive, and frequent infection and weaning failure. Even if you do a tracheostomy, there is no guarantee that you are able to wean them early. So that's why, so you need to consider all these things when you plan for the tracheostomy, because it is a never ending story. Again, they can come with a acute infective exacerbation, dynamic hyperinflation, poor respiratory drive, all these things can happen. So there are some general like evidence for early versus late tracheostomy. So like when it comes to COPD, we don't have a real head-to-head comparison. We have Trackman trial, one of the meta-analysis, okay, but not particularly looked into COPD, that you need to understand. So when to consider tracheostomy in COPD? If at all you want to do tracheostomy, so predicted weaning failure, multiple failed spontaneous breathing trial, persistent hypercapnia, weak cough, high secretion burden. So our patient is having hypercapnic encephalopathy. If sedation and ventilation prolongation are expected, high secretion load, tracheostomy may help in achieving the bronchial hygiene and reduce the endotracheal tube associated trauma. So persistent high risk for VAP, need for prolonged sedation. Okay. So are psychological or rehabilitation goals. Then only you consider tracheostomy in COPD. Otherwise, not a general recommendation for jumping for early tracheostomy in COPD patient, because it is not so easy. It is not a ending story because it's a chronic disease. Okay. So in our patient somewhere between day 6 to day 9, so after total of 7 days on controlled mechanical ventilation for acute and chronic respiratory failure, patient demonstrated gradual improvement in respiratory mechanic, stabilization of hemodynamics and resolution of fever. Sedation was tapered, spontaneous breathing effort were observed with good lung compliance, and day 7 patient was considered for weaning. So the oxygen requirement is 30%, respiratory mechanics improved, stable hemodynamics, secretions are not so much. Okay, he has been given spontaneous breathing trial using pressure support of 8, PEEP of 5, FiO2 of 30%. Okay, so he tolerated the 45 minutes trial. So respiratory rate is less than 28 at the end of the trial. Saturating 92%, heart rate is less than 110, no sweating, no auxiliary muscle usage. So pH is 7.37, PCO to become 52, PO to 82, bicarb 29. Okay, so basically is ready for extubation. So we given an extubation trial. What is the role of NIV in the post extubation in COPD? You want to put this patient on NIV or it is okay. So what is the evidence suggesting on the usage of NIV in the post extubation? So there is a large data, one data particularly I want to comment. So in COPD, okay, so prophylactic NIV versus conventional oxygen, what they have done. So basically like so post extubation respiratory failure which reduced and also reduced the 90-day mortality with NIV. So chronic respiratory disorder with hypercapnia during spontaneous breathing trial. See, they given pressure support ventilation or TPs. Okay, they try to wean, but they are having still hypercapnia. So still they extubated and they put them on the NIV. So it suggests, so like if hypercapnia is there during spontaneous breathing trial in COPD patients, we can safely extubate them to NIV if other criteria for weaning are good. So basically, so this is the data on like NIV, even they failed spontaneous breathing trial with a background of COPD. So this is HFNC plus intermittent NIV versus HFNC alone, high wean trial. Okay. So for COPD at high risk, extubate to NIV alternating with HFNC rather than HFNC alone. But most of the data is favoring towards NIV. You can just go through this data. Okay, so this is a very comprehensive, like some sort of evidence in terms of NIV in COPD post extubation. Okay, so the take home on NIV post extubation, so which is clinically relevant, who benefit most? COPD who are hypercapnic during spontaneous breathing trial and are high risk for extubation failure. So extubate to NIV often alternating with HFNC rather than either oxygenation, plain oxygenation or HFNC alone. So that is the data which I showed this clinical trial, that is high Wien, that is got published in JAMA 2019. Okay. What not to do? Don't rely on NIV to treat established post extubation failure. So you extubated, but patient already in the respiratory failure, then re-intubate promptly if already having a respiratory failure. So if resources or tolerance limit the NIV, HFNC is an effective alternative for prevention, though COPD focused data favor including NIV where feasible, not the HFNC. That is a take home on NIV. Okay. So on stabilization, so the patient was discharged to ward with the following plan, like bronchodilator therapy, pulmonary rehabilitation and physiotherapy, intermittent NIV, so that it helps in preventing the recurrence of the respiratory failure. So what are the long-term outcome predictors in COPD? So how we can predict the outcome? Okay. So factors which predicting a poor long-term outcome in COPD are, so dyspnea at rest with hypoxia and hypercapnia, pulmonary hypertension is there and they have a carpal nail, irreversible airway obstruction despite treatment with beta 2 agonist. Okay. So pulmonary cachexia with a weight loss, severe acute exacerbation in the history, multiple exacerbation. So, or if they are having already other organ involvement like cardiomyopathy, nephropathy, so then long-term outcome is poor in COPD. Okay. So mortality is generally extremely high. So the hospital mortality is around 10%. At 1 year, it is approaching 40% and is even higher for elderly patients. This is the long-term outcome prediction in COPD. So that ends our like acute exacerbation of COPD case discussion. So till we come back with one different case. So like practice at the bedside, so revise, recall, watch this video, take your notes. Very, very important. Okay. Thank you.